Well, good afternoon, everybody. Thank you for joining us today in our first of a series of webinars on data to drive decisions. I'm Carrie Frank, and I'm joined with my colleague, Maria. We'll introduce ourselves a little bit more here in just a second. But our first webinar series topics today is what is in the Colorado All-Payer Claims Database. And then we're going to dive a little bit deeper into what we have specifically on race, ethnicity, and socioeconomic data now and what our plans are for the future. Really important topic to help inform health equity. So thanks again for participating today. My name is Carrie Frank. I am the Vice President of Communication and Marketing and drive all of our public reporting here at CIVHC. Happy to be here with you. And again, I'm joined by my esteemed colleague, Maria de Jesus Diaz Perez. She's the Director of Research and Performance Measurement, and also very involved with our public reporting and all of the race and ethnicity data that we're pulling in. So excited again to be here with you guys today. Just a few little housekeeping items. We do have all of the lines muted right now. I know we're all used to, after COVID, being on Zoom calls, so please ask questions in the chat box. We will try and monitor those as we go. May save some questions for the end, depending on where we are within the webinar. But we are recording this webinar, and we will be posting it on our website. We'll also send slides and a link to the recording to everyone who's joined us today within a week or so, and we'll send out that information so you guys have access to the information afterwards. So what we're going to touch on today, we'll give a quick overview of CIVHC and the All-Payer Claims Database for anybody who may be joining us who isn't familiar. And then we'll talk just quickly, since this is the first one, about the purpose of this webinar series. Then we'll dive into the meat of what's in the APCD and then talk about, again, the race ethnicity data that we're collecting. We'll spend some time answering questions and having like some back and forth. And then we do want to get your input on future topics, and we'll talk about the next webinars coming up. So just in general, CIVHC is a nonprofit organization. We're independent and objective. Our main mission in life is to empower individuals, communities, and organizations. We provide information and support services, and everything we do is really directed at advancing the triple aim, which is better health, better care, and lower cost. We serve a variety of different stakeholders with the patients and consumers and Coloradans right in the center of the circle there. So we provide the information and support to hospitals, employers, nonprofit organizations, government and state agencies, researchers, clinicians, health plans, you name it. And we do provide information to consumers as well. Just quickly on the All-Payer Claims Database, if you're not familiar with how it was implemented in Colorado, it was a recommendation by the Blue Ribbon Commission for Healthcare Reform back in 2008, and it was signed into legislation in 2010. We're one of a handful of states in the nation who has an APCD that's legislatively mandated. Not all of them are. And in 2010, we were named the administrator, CIVHC was, by HCBUF, or by the state agency for Medicaid here in Colorado. In 2012, we operationalized the website and the database and began providing both public and custom requests. And since then, we've just done a lot of work to enhance the database, to bring on new payers, to increase the number of fulfillments and work with stakeholders across the state to ensure that they're getting information. More public data has been released since then, and we're always continually trying to make the data as actionable as possible to all stakeholders. So what we do with that information, we again provide public data, which is a lot of what we're going to be talking about today and some of the things that you can find online. That Shop for Care tool that I was mentioning, that's a consumer tool that has shoppable prices and quality information. And then we have interactive reports and publications that are more focused on community level and population level information. And then we also have the ability through our administration of the APCD and the way the legislation was written to be able to provide custom data as well. So we license data again to all of those stakeholders that I mentioned to you before for innovative projects, and everything that we do again is always focused on driving the triple aim. So any project that we support has to have a component that makes sure that it is either lowering costs or improving the health or the quality of care for Coloradans. So this is the first of our Data to Drive Decisions webinar. The purpose is to demonstrate what the APCD has in it and highlight the capabilities of the analytics that we have available to all stakeholders. The audience for this is not lay people, so we are going to get a little bit more into the weeds about what we have. So the more experienced healthcare audience and health data users. This series went out to our state agency partners, legislators, our board, our advisory committee members, data users, and our data release review committee. So it's a little bit of a smaller audience. We will be doing more broad webinars to more of a layperson audience over the next year. That's part of our strategy to get the message out also beyond more of our data wonky people. And we are frequency wise going to do these every month, every third Thursday like we are today, from 12 to 1. And topics have been set for the next several that we'll talk about at the end. But again, we are really excited to hear from all of you of what would be helpful moving forward. So one thing that we get a lot of questions about, it's called the All Payer Claims Database, but it doesn't have every single payer in it. So we do get a lot of questions about the number of lives that are in the database, what's represented, very specific questions about what types of claims we get, and what kind of information is in the APCD. So we developed a resource very recently that is we are calling it the Co-APCD Insights Dashboard. And it's a very robust tool on our website that I will show you guys here in just a minute. But it is available on our website under the Get Data tab, What's in the Co-APCD tab. And we'll go through that and the different options that you have to understand the contents in just a minute. But just at a high level, this is a summary picture of what's in the APCD. So in terms of percent of insured population, we estimate we have about 65% of insured Coloradans represented in the APCD. And I should note that this is medical coverage only. So we pulled out just medical coverage. And when you look across all payers, we have about 3.4 million lives, unique lives that we represent in the Colorado All Payer Claims Database. If you look at medical, pharmacy, and dental, it's closer to about 4.5, and you can do that on the dashboard, and I'll show you how to do that. When we look at the types of payers that we have in the database, we do have 375,000 Medicare Advantage. That's that first NA. And the reason that that is NA is we are comparing to the census data to estimate what percentage of covered lives we have by payer type. So we don't have estimates that we were able to find, especially in the census data. So even though we're capturing a large portion of those people, we don't have the denominator from the census data, so we're unable to give the percentage. But we do have Medicare. We have estimated 63%. We do get feeds from Medicare fee-for-service, and we have 100% of the Medicaid population, excuse me. And then in terms of commercial payers, we estimate we have about 34% compared to what the census data says that we have here in Colorado. And that's broken down into the majority of what we're capturing is fully insured, not as many of the self-insured lives, which we'll talk about why that is the case here in just a second. So I think it's a little easier to think about what we're not capturing in the APCD because it is very robust and does represent a high portion of the population. But the big buckets are a federal program, so we do not get at this point in time any information from VA or TRICARE programs and the Indian health systems. We are working with the VA. We've actually been in contact with them for about 6 or 7 years now to try and work something out to try and capture some of those claims. So fingers crossed that will actually happen at some point in time, but that's a big hill to climb when you're looking at trying to get new information from a federal program. We don't have the uninsured in the database because if there's no claim associated with it, we do not get a submission. So we do not have uninsured lives. And then as I was mentioning before, self-insured employer plans, there is actually a Supreme Court ruling that happened several years ago that does not allow any states that to actually mandate submissions from ERISA-based self-insured employers. So we are capturing those that are not ERISA-based and estimate we're getting about 25% of the self-insured. We do have some voluntary ERISA-based self-insured employers who are submitting, and we're continually working on that. That's a big goal of ours, and in partnership with the state and some of the alliances that are forming here in the state. So we're looking forward to those numbers continually increasing over time. But right now it's a slow process to try and capture those claims. So in terms of the Insights dashboard, just some high level information. It does provide trend information. So if you're trying to understand how does the database look back in time, we have the information available from 2013 to 2020. So you can sort by the different time periods of relevance, and you can see the trends in how many people are represented in the APCD and what types of coverage they have. So medical, dental, and pharmacy, because I know that those are big buckets that people are very interested in understanding. You also can see how many payers like in the commercial lives space. So we have by payer, individually named payer information in the Insights dashboard. And we also have information that will help you understand by payer, how many people they cover and what type of coverage, again, in those buckets of medical, dental, and pharmacy, and self-insured versus fully insured lives. And then also those breakdowns is very important to understand what portion of the population is being covered, and not just at the statewide level, but all of our counties are very different with the payer mix and self-insured versus fully insured. So we also have breakdowns by the county of interest that you might be interested in understanding what portion of the APCD or people in that county are covered by the APCD. And then we do get a lot of other questions in terms of other types of services. So behavioral health services is also a tab on the APCD Insights dashboard, which is not a claim type, but we are able to capture behavioral health services by looking at codes, and we'll talk about that a little bit more as well. So let me actually jump out. It's more exciting, I think, if I can demo for you what this looks like. So if you go to our website and you're on this home page, you can go to the Get Data tab, and under Co-APCD info, you have an option to select what's in the Co-APCD. So once you're on that tab here, we have some information at the top, some of those considerations. One thing to note right now, the data is only through June of 2020 at this point in time. We will be updating this frequently. And so after our July refresh, we will have a full calendar year 2020. And so we'll update the whole entire dashboard so that you will be able to see what the full 2020 looks like. So when you are looking at 2020 right now on the dashboard, it's going to look about half of 2019, which makes sense because it's just the first 6 months. So this overview tab here, let me move let's make it a little bit smaller so we can see the whole thing. When you're on the overview tab, you have some options to have instructions. If you're not really sure how to use it, you can click this button and it kind of tells you some of the things that you're looking at. You have the ability to select by payer types on this left-hand side. So if you're only interested, for example, in Medicaid, you can click on that button here. If you want to look at just one select year, let's pick 2019 since it's our last full year of claims data. Then you can see how many claims in total that we received from Medicaid in that year. And then you have the breakdown by medical claims versus pharmacy claims versus dental claims. If we want to go, but let's go back to all payers here. So in 2019, we had across all payers 102 million claims that came in. And again, you have that sortable breakdown here. We have 42 total payers. That includes Medicaid, Medicare, all the commercial payers. So we receive claims from all of those folks. With the exception of Medicare, we get them on a monthly basis. And then that represents about 5,000 people. Again, it's closer to probably 4.5, but this is unique lives in the APCD, but that could be people that may not live here anymore. And we capture those folks and keep them in the database, but at any given point in time, we may have more represented. It just depends on what point in time we're looking at here. In terms of the breakdowns by payer type, I think it's very interesting to be able to look at all of the different commercial payers. So Colorado is special in that we have a lot of commercial payers. Not all states have so many payers. And some of these payers are just going to be dental payers. So the breakdowns by medical, pharmacy, and dental, right now we're just looking at Aetna. And this is their insured people with claims, 500. But if we're looking at an isolated year, we'll go back to 2019 again. Their total insured folks is about 231,000. Of those 231,000, 148,000 people had claims. Again, we have the option to see what type of claim. So a lot of pharmacy, a lot of medical, not as much in the dental space here. And then we also have the breakdown by the number of people with self-insured that Aetna submits on behalf of, and then the number of people who are fully insured here. And then if we go to the next tab over, it's the insured people by population by county. As I mentioned before, sometimes if you, let's take Summit, for example, they were very interested in understanding what population was covered in Summit for the work that they're doing with Peak Health Alliance. And they're using this as a way to encourage self-insured employers who are working with the Alliance to submit their data, since that's a voluntary submission for most of them that are self-insured. So right now, we estimate for Summit County that we're capturing about 48% of the total population in Summit County, so roughly half. And then if you look at the denominator of how many are insured based on the census data, we're estimating that we capture about 57% of the population. So they're again using that as a tool to help encourage employers to submit their data so that we can get more of a larger portion of the population represented. And if you did select just commercial, that will sort this data even more. So when you're looking at just the commercial population, commercial represents about 25% of the total population. And then we have about 36% of the commercial population in the database for Summit County. So lots of stuff that you can do with that tab. Again, that's all based with, as the denominator is the census data. So it's not 100% accurate, but it's the best that we have here in terms of being able to sort by the type of payer. Behavioral health services is something that we've been capturing in the database for a long time. We've gotten better at it, I think, in terms of the submissions over time, and you can see that reflected here in the trend information. Again, this is not a claim type that gets submitted, but we have a whole list of CBT codes and other types of codes that we look at to estimate what and put them in the bucket of behavioral health services. So you can see that we have had an increase in total claims for behavioral health services over time. So we have about 8 million in 2019. And then that's growing as well. And when you look at just the number of unique lives with one or more behavioral health services, that has grown over time. And I'm sure it'll be interesting to see, given COVID last year in 2020 and the increase that we've seen in telemedicine with behavioral health services, to see, I'm anticipating this number will jump quite significantly when we have the full 2020 claims in this Insights dashboard. It'll be interesting to see how different the jump is, the percent increase. And a couple other quick things that you can do here. These are all trend information too. So you can see how over time we have increased the number of payers. So we had back in 2013, we had about 23 payers, 2014, and we've been jumping up over time. And this is by the claim type. So you can sort by medical here, number of payers who are submitting pharmacy claims, and then the number of dental submitters as well. Similarly, you can look at total claims over time by the claim type also, and total people by year, and then the population over time as well. And this is also broken down options to give yourself some insights by county as well. So there's a lot you can do with this, and our hope is that this is a tool that pretty much any kind of content of the APCD question that may come up for any of our stakeholders, this is a good resource to check into. If there's ever something that you don't see here that we could add to this, we are collecting feedback. This is our first release of this information, and we want to be able to continue to add information over time. And in fact, that is a good segue for me to go. I want to point to a couple more resources, because since we created this, we did get several requests to have a downloadable document that has all the contents that we just showed in the Tableau report. This is a downloadable Excel file that has all of the data available if there's a need for you to look at it in different ways. The behavioral health and substance use claim information that I showed you or was talking to you about before in terms of the types of claims, that's all listed in this downloadable Excel file. We'll talk about race and ethnicity data as well as dental and vision information. But this is where all of the resources that I'm about to go back to my PowerPoint presentation and show you, that's where you would get access to those. So let me pop back in. So this is again, all other resources that I just mentioned. The behavioral health and substance use disorder services analysis does break down both behavioral health services over time from 2017 to 2019, and then also substance use disorder claims. And then there is that list of the ICD-10 codes that are considered behavioral health related, so that you can understand what goes in. A lot of things get categorized as behavioral health, but substance use disorder is separate from behavioral health. It's a separate category of behavioral health that isn't something that we have historically been able to capture because of federal regulations, but things are changing. The CARES Act actually expanded uses of substance use disorder data. That is going to broaden the ability to use substance use disorder information and capture it. So right now, many of the payers are not submitting data to us related to substance use disorder because of the federal regulations that say if it was paid for, if it's actually a treatment that it is occurring in a facility that gets paid for by the federal government, that it can't be shared. But this is the CARES Act is going to help relax that. So we're just now figuring it out. We're starting to look into the regulations, starting to define how we can use substance use disorder data, for what purposes, and how that data can be released. Just establishing some business rules around IDing that data in the database once it starts coming in, and making sure we're partitioning it if we need to separate it out, so that we are appropriately using that data. We're also in the process of working with Medicare to request a separate substance use disorder file to supplement their submissions that they give us that are separate from substance use disorder. And then we're also working with Medicaid to make sure that we're aligning definitions. And once we do all of those things, we'll start working with the commercial payers to figure out, how do we engage them and help them understand how to submit the data and what those requirements might look like. So we're a little ways off from having that information. It's not going to be a quick process because we want to make sure we dot our I's and cross our T's. It's important to get this right and protect privacy. But we are excited that that will be information that stakeholders can start using eventually, depending on the regulations in place. But a lot of good research has been prohibited in the past because of this regulation, and they've known that they needed to find some solutions at the federal level. So the CARES Act is helping implement that. I think we might have had a question, so hold on just a second. Oh yes, just a reminder to feel free to chat in the chat box. Thank you. All right, so I mentioned that we have extra information on dental code claims, and this is again under the resource tab on the web page that I just shared with you on the Insights dashboard. But we've had some questions regarding what we have for dental information. So this analysis that's available, and this is just a snippet of the data that's available in the Excel file. We have the top 300 dental codes. So you can see on the left-hand side, the CPT, the specific dental CPT, what the procedure description is, and then over time, what the volume of claims looks like. Again, this doesn't go all the way through 2020, so that doesn't complete the picture there, but you can see increases in the volume of claims that we've had over time for dental. And vision claims is another one that we get questions about. We don't have this as a requirement in the APCD data submission guide for payers, so it's not really robust in terms of commercial, but you can kind of capture from the Excel file that we are getting some claims. The majority of claims coming in for vision are actually from Medicaid. But we do have some. So if there's a project that anyone's interested in terms of Medicaid specific vision information, we certainly have claim volume that would support that. This might be something that we collect in future data submission guide changes, but we're in the process of figuring out priorities for the next coming years. So we'll see where that falls. So we will be updating the dashboard that I just mentioned every 6 months or so. We'll probably try and incorporate some of that information that I just shared with you, the vision, the SUD claims, the dental claim information too, but we're asking for any feedback that you might want to see in the dashboard that would be helpful for you. Again, it's going to occur probably after our July 2021 refresh that will help us have a full calendar year 2020. Feel free to send me any direct feedback or directly to our info@civic.org. We've also had some folks recommend that we have age and gender distribution information. So not only just the population numbers, but how does that look in terms of age breakouts and male versus female, etc. And then number of people covered by the self-insured employer plans. I think we can do more to break out that information. And because of some of the conversations during the legislative session, we've also had some requests for breakouts by large group, small group, and individual plans as well. So looking forward to enhancing the dashboard in the upcoming months, but please, again, feel free to reach out if you have additional suggestions. And I'm going to turn it over to Maria. She's going to talk to you all about our race and ethnicity data and all the great work she's been doing in that space.
Hey, good afternoon, everyone. I hope you are all enjoying this sunny afternoon. Thank you for joining us. As Gary mentioned before, the race ethnicity data was also shared in the same space, which is what is in the Colorado APCD data. And the motivation behind that is, again, like all the questions that we receive from several stakeholders about what is the state of the race ethnicity data in the Colorado APCD. What you're gonna find in that resources section that Carrie showed is a spreadsheet that looks like the one in the screen, and you have the count and percentage of all the data fields that are related to race and ethnicity in the Colorado APCD. The data that is shown for 2019 and 2020. And it shows also the breakdown by payer type, that is all the commercial payers, Medicaid, Medicare, and Medicare Advantage in some cases. Could you go to the next one, Carrie, please? The intention of showing this data is not so much to represent the race ethnicity distribution in the Colorado APCD, because as, when you look at the data, you're gonna see, this doesn't look like the race and ethnicity distribution of our population. It doesn't yet. But it was also motivated by the fact that in 2019, late 2019, 2 of the race and ethnicity fields became required for our submitters to provide. So for such, since the Colorado APCD was established back in 2012, as Kerry mentioned, these race and ethnicity data fields have existed, but they were submitted only in voluntary basis. So the data was very limited and just mostly incomplete. In late 2019, the regulation changed and 2 of these data fields became required. The 2 data fields required are race and one that is a Hispanic indicator. The Colorado APCD is closely following the model that is the federal government model from the Office of Management and Budget. And that model recognizes only one ethnicity, which is being Latino or Hispanic, and a minimum of 5 races in a different field. Those are the fields that are required now in the APCD, but we also collect another 2 more race fields and 3 more ethnicity fields. So in total, we have 7 data fields that refer to race and ethnicity. Could you go to the next one, Gary? Okay. Usually following the model of the Office of Management and Budget, what you do is you do a combination of the ethnicity field, so you are either Hispanic or Latino or not, and the race fields. In this case, the race fields are white, Black, American Indian or Alaska Native, Native Hawaiian or other Pacific Islander, and we also have an other race field and an unknown field. In some cases, some of the payers, and I think that's Medicaid, uses also the more than one race. But most of our submitters only have the 6, including other and unknown. When we do the combination of race and ethnicity, what you have is like they are independent fields. So you can be Latino white or you can be Latino Black. So that's the creation of these mutually exclusive categories. And the reason I am showing them to you is just to point out that even when these 2 fields have become required, that doesn't mean that they are complete or they accurately represent the distribution of race ethnicity in the state of Colorado. For example, the blue bar represents the percentage of reported as unknown by commercial payers, which is still very large. We only have 1 payer in the state of Colorado that reports race and ethnicity in a very complete manner, and that would be the Medicaid state agency. But for the other payers, we have still a lot of work in front of us. Next one, please. So the next steps to improve this, we have to take this data, and that's the way that's one of the reasons also we are sharing. This is a data, is a baseline in a way, because these data fields became required just last year. And we are working actively with payers to capture more complete race and ethnicity data. We are also updating the data submission guide to give a more precise instructions for this coming year, and also in the future to add more specific race and ethnicity field, and potentially add another variable or data field that provides information about the language that members or patients have. But because all this information is being improved, and we are actively working on to increase the capabilities of the Colorado APCD of informing healthcare equity and health equity in general. One of the other initiatives that we have been working on is geocoding the Colorado APCD. And we're going to be talking a little more about that. So first of all, what is geocoding, right? In the Colorado APCD, we receive information about the members who are covered and about the providers who provide the services. All these members and these providers have addresses. These addresses are, the process of geocoding is a computational process to assign a latitude and longitude coordinate, and that coordinate provides us with the ability of adding a geographic identifier. In our case, we have linked with a geographic identifier using the census model. So that will, and we used an external tool to do that, and we have completed that phase of the work. So that is very exciting, and we'll talk more about why this is exciting. This is exciting because we are now going to be able to speak about the context which each of the members in the Colorado APCD lives, works, and play. We're going to know if they have what is at the community level, the characteristics of their housing at the community level, what is the socioeconomic status at the community level. They have what is the limit in transportation access, for example, and income, race, ethnicity, and many other variables that can provide great information to speak about opportunities of improvement for healthcare and healthcare access and healthcare quality also. Having these geographic identifiers is going to allow us to use census data to speak to socioeconomic status variables and other variables, but also to many other data sets that are already available publicly that have aggregated a series of other pieces of information. You can also have information about the environment. You can have many different types of information. Could you go to the next one, Carrie? For example, you also know this is another thing that having geographic identifiers is going to allow us to do. If you are familiar with the data we present in our website, you know that we always present the information at the Division of Insurance region, at the county level, and in some cases we have presented the zip code level because that is the only information we have geographically in the data set right now. But now that we have the geographic identifiers, we can aggregate the information in much smaller geographic units like census tract from the census. The geocoding also allows us to have specific locations of members and providers. And that serves to answer questions like how far a determined patient has to drive to receive primary care services. We can actually use software, specialized software to estimate the traveling time, and instead of just a gross estimate that goes from the centroid of a zip code to another centroid of a zip code. So this is going to allow us for much more sophisticated and important analysis in terms of access to care. Next one, please. And these are courtesy of our great data analyst, Katie Oberg, who has been working very hard in the geocoding project for the Colorado APCD. Just to give you an idea of the level of information that having the possibility of displaying the data at a smaller geographic unit is going to give us. Look at the northeast region of this map. This is the prevalence of high cholesterol by county. We don't have the legend, but let's think that the darker means higher percentages of high cholesterol. So, and now look at could you go to the next one. And this is the same variable, but now is broken by census tract. What you see is completely different, and what you see, depending on who you are, let's say that you are a provider working in the Northeast quadrant. Now you know that you don't need to, you have much more precise information on where the population that are at high risk are in your area of service. Before you just had like the whole county as a whole, and you know those rural counties, so that's really not very helpful. Now you have much more information to actually target your resources if you are a provider, and if you are a researcher, is that if you target and you can find different types of relationships that are much more important. Next one, please. So the potential is great, as I mentioned before, because there are many data sets that are already available that use this type of geographic identifiers from the census. And we can link information from surveys that are available at the census tract level or at the county level, like health behaviors, socioeconomic information, as I mentioned, but also environmental variables. Like we know that air pollution and exposure to some chemicals can have important effects in the health of populations, and now we might have the possibility to do that. So we are very excited about the potential. Could you go to the next one, please? So we completed the phase of geocoding all the addresses. As I said, the addresses of patients and the addresses of providers. And this data is already living in the data warehouse. So every patient has not only an address, but also a geographic identifier that will allow us the linkage. In the near future, we will have a series of variables of socioeconomic indicators that are like most commonly used. But until we develop all of them, we will be creating those on an ad hoc basis. We are planning to do this annually. So every year we will be geocoding any new addresses that are submitted to the Colorado APCD. It is important to mention, of course, that we will be able to link our information with other data sources as long as they are available at the census tract level. For example, many surveys that are great information, the way they conducted their sampling, they are not available at the census tract level. So even if we want to link them that way, we will have to rely on county or zip code or anything that is available. But it is still giving us a whole new a series of opportunities of improving the context that we can provide to the healthcare data quality and healthcare access that we provide regularly in the public reports. And that's all I have to say for that. Thank you, Carrie.
Thank you, Maria. That's great. Wanted to remind everyone that you have the option, if you would like to ask any questions, feel free to use your chat box. As we're waiting for questions to come in, let me go ahead and move forward to just to let you guys know. So we will be sending out registration links for the upcoming events that are, again, each of these is the third Thursday of the month. We have scheduled in June on the 17th, Data to Combat COVID-19 and Exploring Post-Pandemic Telehealth Services Utilization. We have a robust telehealth services analysis on our website, and we have other data available as well that can be used, and we'll be sharing that information. I'm looking at July to talk about improving population health, specifically looking at low value care and what we learned with our first run of low value care with the database, and where we have opportunities to improve care and lower costs. And then also county and DOI specific metrics that we have available in our community dashboard. We'd love for participants to give us some feedback on the community dashboard, because we're in the process of updating that, and would love to get input from those of you who may have used it or may want to use it and have some thoughts on how we can make that better in the next iteration. And then in August, we're looking at efforts to transform the way healthcare is delivered and paid for. We are about to release an alternative payment model report here in the next couple of weeks. And we also have upcoming drug rebate information that will be going out. And we did release a Medicare reference-based price analysis based on the RAND Corporation study. So we'll be going over all three of those reports in the August meeting. But again, we are very excited to hear from those of you who are interested in this space and of what would be valuable to you that we bring to you in the Data to Drive Decisions webinar. So if you have any feedback for us, please let us know. You can either chat it right now, you can send it to Stephanie. Oops, I don't know what happened just there. But we will be collecting that information, and we would love to hear from all of you out there doing the good work on the ground. So I don't see any questions, and we'll let everybody get 15 minutes back in their busy lives today and enjoy this beautiful weather. As Maria mentioned, hope you guys get to go outside. So thank you guys for joining us today, and we look forward to hearing from you and seeing you on the next webinar. Have a great day.
Thank you, everyone. Bye.
Thanks.